Egypt has one of the highest prevalence and burdens of hepatitis C worldwide, and so in order for Egypt to achieve hepatitis C elimination by 2030, innovative models which increase access to testing and treatment need to be implemented. Our initiative, which is considered unique, has led to social movement in Egypt and can be used as a model for replication. Through this initiative, we provided on-the-ground community-based activities which can be replicated in countries with a similar context within their communities. We are offering this model to increase attention to, investment in, and action for a set of cost-effective interventions and policies that can prevent and eliminate hepatitis. El-Osmaniya was chosen as the first village for this program because the village's community leaders had approached the Egyptian Liver Research Institute and the hospital to assist in treating HCV patients in their village. To implement this project, 4 distinct activities were undertaken: community mobilization and the establishment of partnerships, an educational campaign to raise awareness and promote behavioral changes, fundraising for public donation within the local communities, and finally, comprehensive testing, diagnosis, and treatment. Community mobilization and establishment of partnerships involved implementing the project activities through community-based association and 60 village promoters. These village promoters are volunteers who are the village insiders, willing to serve their communities. Some of them were from El-Osmaniya Charitable Patient Association, and others were part of the Rural Health Unit who worked as health promoters for encouraging family planning. The educational campaign to raise awareness and promote behavioral change used a wide range of complementary promotional educational tools and dissemination channels. These are developed by professional team of the Community Medicine Research Department under my supervision at the National Research Center of Egypt to raise awareness, out of which are 4 booklets. One is how I can manage being hepatitis C patients. Second is how to protect myself from catching hepatitis C. The third one is information for the paramedicals and how to manage. And the last one is way of supporting hepatitis C patients. The messages of the educational campaigns focused primarily on good practices to reduce HCV transmission that could be adopted by villagers directly rather than by healthcare providers. Before starting our campaign, and with the help of the village promoters, we mapped the whole village into 4 blocks and mapped all the facilities within each block, including primary healthcare units, dentists, clinics, private clinics, schools, pharmacies, mosques, coffee shops, barber shops. We targeted each of these facilities with our messages. Actually, for example, we have 4 barber shops, 1 in each block. We targeted the barbers and educated them about the dangers of sharing personal tools like razors as a source of transmission of infection. We used our developed models, modules, and also songs and cartoons for this. Now the barbers use a separate razor for each individual, which are labeled and kept at the barber shop. The cost of the test and treatment program and educational campaign were mostly funded by RAIA. Additional funds were raised using the principle of zakat. Zakat is an Islamic way to address financial barriers for the poor, through which the rich pay for the poor to access treatment and care. During implementing this initiative, one of the challenges we faced was first changing the villagers' wrongly perceived method of transmission. People believed that one could get hepatitis through coughing, food, shaking hands, hugs, mosquitoes, or that hepatitis could be caused by bilharziosis, drinking contaminated water, or diabetes, and that they could be treated by herbs. At the start, people were also not interested at all in changing their behaviors that could lead to hepatitis prevention. Their main concern was about being treated and not to be informed or educated by the healthy behaviors at all. Several strengths of this model contributed to its success. First, a comprehensive and integrated approach was used that incorporated both preventive approaches to reduce transmission and new infection, with testing and treatment to reduce burden of disease and associated morbidity. Second, since patient is key to achieve implementation, this model was dependent on outreach program of testing at the household level to ensure high coverage of the village and maximize the reach and engagement of the patients. Third, a wide range of complementary promotional educational tools was used to raise awareness. Finally, and most importantly, is that there was very strong community engagement with great commitment to implementing the project activities through the community. The engagement of the village promoters, who are acceptable to their local community, facilitated getting in depth with families and understanding their behaviors that lead to the endemicity of viral hepatitis. Their engagement also ensured sustainability.